Hello everyone, in this video we will discuss iron deficiency anemia. Iron deficiency is the most common nutritional disorder globally. This is characterized by inadequate hemoglobin synthesis due to lack of iron. Hemoglobin is a blood pigment composed of heme and globin. Heme is composed of iron and porphyrin ring. So whenever there is deficiency of iron, this will result into the decrease or inadequate hemoglobin synthesis. There are certain high risk individual or high risk groups in which there is high chances of development of iron deficiency in anemia. First is toddler or children. Due to low iron in the milk and high growth demands in this age group. Second group is adolescent girl and women of the childbearing age due to blood loss in menses and pregnancy. Elderly individual often due to occult GI bleeding or poor dentition or diet. So these are the three high risk group for the development of iron deficiency anemia. Now we will see iron distribution and metabolism. Body iron is strictly regulated because free iron is toxic and it is divided into two main compartments. 80% of body iron is present as functional iron in the form of hemoglobin, myoglobin and enzymes such as catalase, cytochromes, and 15 to 20% of iron is present in the form of store iron like ferritin and hemocitrin. Ferritin is a soluble store form of iron present in liver macrophages, and this is the primary source of iron store. Hemocitrin is insoluble, normally seen in iron overload, and this can be visualized with the help of Prussian blue stain. Now we will see the metabolism and absorption of iron. Iron is predominantly absorbed in proximal duodenum, and the absorbable form of iron is ferrous. This ferric form is converted into ferrous with the help of duodenal cytochrome B. So dietary iron is present in mainly two forms: heme iron and non-heme iron. Heme iron primary source is animal food products, and non-heme iron is predominantly present in plant-based source. Heme iron is very efficiently absorbed with the help of HCP1 or heme carrier protein 1 in the enterocyte of duodenum. Non-heme iron is poorly absorbed, and this absorbed with the help of DMT1 divalent metal transporter 1 in the duodenal enterocyte. Once the iron reaches into the enterocyte, here the iron is transported from enterocyte to the circulation with the help of ferroportin. In the circulation there is a protein named as transferrin which acts as a carrier protein for iron transport in the plasma or in bloodstream. This transferrin transport iron to the various sites like bone marrow for erythropoiesis, and some of the iron to the liver in the form of store form in ferritin or hemocitrin. Whenever there is deficiency of iron due to any reason, due to decreased dietary intake, blood loss or any reason, whenever there is low iron is not available for the erythropoiesis, and there is iron deficient erythropoiesis, or this ultimately result into the development of anemia, microcytic hypochromic anemia. Low iron, low hemoglobin, and ultimately the result of anemia. Hepcidin is one of the very important protein which play very important role in iron absorption and metabolism. It is the gatekeeper of iron metabolism. Primary source or it's synthesized in the liver. Mechanism of hepcidin is it binds with the ferroportin and causes the degradation of ferroportin. Ferroportins are the exit channel for iron in enterocyte and macrophages. As we have discussed, during the absorption, ferroportin help the iron to transfer from enterocyte to the circulation, and they are also present into the macrophages. So if the ferroportin is degraded or not working, this will result into the decrease availability of iron. Hepcidin is the inhibitor of these ferroportin. That's why hepcidin is a negative regulator of iron. Whenever there is high iron overload or inflammation, this will increase or stimulate the more hepcidin synthesis, and ultimately this decreases iron absorption. And conversely, when there is low iron or hypoxia, this causes decreased hepcidin synthesis and iron absorption is increased. Now we will see the etiology behind the development of iron deficiency anemia. There are four main categories for iron deficiency anemia etiology. First is chronic blood loss due to any reason. This is the most common cause in high income countries. Whenever any adult male or postmenopausal female come with the complaint or findings of iron deficiency anemia, we must rule out the GI malignancy. Second category is increased demand of iron. This is particularly seen in pregnancy, infancy and childhood and adolescent. Because of the growth, there is increased demand of the iron. Third is impaired absorption. Iron is defective in absorption. In these conditions like celiac disease, gastrectomy due to loss of acidity promotes iron absorption. Diets high in tannates and oxalate, so these conditions impair with the iron absorption. Fourth condition is dietary intake. Low dietary intake can be seen in low income regions or individual with restricted diet like vegans and elderly individual. So these are the four main causes of iron deficiency anemia: blood loss, increased demand, impaired absorption and dietary deficiency. Now the clinical symptoms seen in iron deficiency anemia, sign and symptoms. Neurological sign and symptoms like headache, dizziness, cognitive changes, issues with the concentration, unable to concentrate on a task. Musculoskeletal symptoms like severe fatigue, lethargy, weakness, muscle ache. Psychological or behavioral changes like irritability, restlessness, poor performance in task. In GI, loss of appetite, dysphagia can be seen. On examination, there is pallor, glossitis or angular stomatitis can be seen, and a typical finding of spoon-shaped nails known as Koilonychia can also be seen in severe cases, and a feature of Pica in which craving for non-nutritive items like ice, dirt and clay can be seen in the cases of iron deficiency anemia. In cardiovascular system, there is tachycardia, shortness of breath and heart murmur can be seen in the severe cases. So these are the a clinical feature of iron deficiency anemia. In the complication, There can be cardiovascular issue in severe iron deficiency anemia, pregnancy complication like preterm or low birth weight, and there can be a developmental delay in the children. Some of the clinical features, specific clinical feature of iron deficiency anemia are Pica, in which craving for non-food items like dirt, ice, flour, clay is seen. Koilonychia is spoon-shaped nail. Plummer-Vinson syndrome or Patterson-Kelly syndrome. This is a triad of iron deficiency anemia, atrophic glossitis, and esophageal waves. How to diagnose iron deficiency anemia? Whenever patient presented with the clinical symptoms like fatigue, weakness, shortness of breath, we perform complete blood count and reticulocyte count. In iron deficiency anemia, there is decreased hemoglobin level, MCB is less than 80 femtoliter, MCH is low, and red cell distribution width is increased due to variation in cell size, and reticulocyte count is normally low or normal. On peripheral blood smear, there are microcytic hypochromic cells. Then to confirm the diagnosis, we advise serum iron studies, in which there is decreased serum ferritin level, low serum iron level, low serum transferrin saturation level, and increased total iron binding capacity. So this complete blood count with iron study confirm the diagnosis of iron deficiency anemia. On morphological finding or examination, peripheral smear shows microcytic hypochromic cells. Like these are the microcytic hypochromic cells, smaller in size with increased pallor. These are the microcytic hypochromic cells. On bone marrow examination, there is absence of stainable iron on Prussian blue stain is the gold standard for diagnosis. There is no iron available in macrophages of bone marrow in iron deficiency anemia, so there is no staining, and this used as a gold standard for diagnosis of iron deficiency anemia. For the treatment of iron deficiency anemia, first to rule out the underlying cause and address the cause. Iron deficiency anemia can be due to the blood loss or dietary deficiency. After addressing the cause, there is an option of iron replacement therapy, which can be given as oral iron or in the form of the IV iron based on the requirement of the patient. The response to iron deficiency, response to the treatment are initially in first 2 to 4 weeks, lab test shows increased reticulocyte count and symptomatic improvement into the patient. In 1 to 2 weeks, there is increased hemoglobin level, and finally replenishment of the ferritin store. So this is the response of treatment. Initially increased reticulocyte count, then hemoglobin increases, and ultimately replenishes the iron stores in the form of ferritin. Now we'll see some important points for the exam NEET PG, FMGE and INICET purpose. Most common site for iron absorption is proximal duodenum. Best form of iron absorption is ferrous. Storage forms are ferritin and hemosiderin. Ferritin is the most common and soluble storage form. Hemosiderin is insoluble and normally seen in iron overload. Gatekeeper for iron metabolism is hepcidin. It decreases the iron by degrading ferroportin. Transport protein for iron is transferrin, which is synthesized in the liver. Enhancer of iron absorptions are vitamin C and gastric acid. Inhibitor of iron absorption are tannates, phytates, phosphates and calcium. First to decrease in iron deficiency anemia is serum ferritin due to decreased iron store. Second is serum iron level and increased total iron binding capacity. Third change is anemia due to decrease in hemoglobin level, and fourth change is microcytosis and hypochromic condition. Soluble transferrin receptors are increased in iron deficiency anemia but normal in anemia of chronic disease. This is a very useful marker when iron deficiency anemia and inflammation coexist. In iron deficiency anemia, there is no iron available to bind with the transferrin, so there is more free or transferrin receptors are available. That's why they increase in the iron deficiency anemia and they are normal in the anemia of chronic disease. Zinc protoporphyrin increased in iron deficiency anemia because iron is missing and zinc is incorporated into the protoporphyrin ring, and this can also be seen in the lead poisoning. Thank you.